السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the two physiology lectures on the cardiac cycle in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for these two learning activities. And here we have the recommended learning resources for these two lectures. We mentioned in the previous lectures that the heart functions as the central pump of the cardiovascular system, and that in fact we have two pumps in the heart. The right ventricle or the right-sided pump, which functions as the pump of the pulmonary circulation, and the left ventricle or the left-sided pump, which functions as the pump of the systemic circulation. In the heart we have valves at the entry and exit points of the ventricles. The valves which we have at the entry points of the ventricles are the atrioventricular valves. The tricuspid valve at the entry point of the right ventricle between the right atrium and the right ventricle, and the bicuspid or the mitral valve at the entry of the left ventricle between the left atrium and the left ventricle. And we have also valves at the exit points of the ventricles. These are the semilunar valves, the aortic valve at the exit of the left ventricle between the left ventricle and the aorta, and the pulmonary valve at the exit of the right ventricle between the right ventricle and the pulmonary trunk. The valves allow blood to flow in only one direction. When the atrioventricular valves are open during diastole to allow the ventricles to be filled with blood, the semilunar valves are closed in order to prevent the backflow of blood from the aorta into the left ventricle and from the pulmonary trunk into the right ventricle. And when the semilunar valves are opened during the ventricular systole, the atrioventricular valves should be closed in order to prevent backflow of the blood from the right ventricle into the right atrium and from the left ventricle into the left atrium. Hemodynamically, the opening and closure of the cardiac valves occur as a result of pressure gradient across the valves. The cusps of the atrioventricular valves are held by the chordae tendineae to muscular projections known as the papillary muscles. This is important because the papillary muscles limit the movements of the valve and prevent the eversion of the valve during ventricular systole. However, it is important to note that the papillary muscles themselves, they do not open or close the atrioventricular valves. Here we have another diagram for the cardiac valves. These are the atrioventricular valves, the tricuspid valve and the mitral valve, and these are the semilunar valves, the aortic valve and the pulmonary valve. This is the mitral valve when it is open, and here we have the mitral valve when it is closed. And these are the chordae tendineae, and these are the papillary muscles. This is a closed semilunar valve. Each semilunar valve is composed of three cusps, and this is an open semilunar valve. Here we have the mitral valve open during left ventricular diastole to allow for left ventricular filling, so the blood flows from the left atrium through the open mitral valve into the left ventricle. While the mitral valve is open during left ventricular diastole, the aortic valve should be closed in order to prevent backflow of the blood from the aorta into the left ventricle. When the left ventricle begins to contract, it closes the clasps of the mitral valve in order to prevent the backflow of the blood from the left ventricle into the left atrium, and it opens the aortic valve so that the left ventricle ejects oxygenated blood into the aorta. The main topic of these two lectures is the cardiac cycle or the heartbeat. The cardiac cycle or the heartbeat consists of alternate periods of systole, where we have contraction and emptying, and diastole, where we have relaxation and filling. The duration of one cardiac cycle or one heartbeat at rest is 0.8 of a second when the heart rate is 72 beats per minute. The duration of the cardiac cycle is shortened when the heart rate increases. It is important to note that the atria and the ventricles go through separate cycles of systole and diastole, and the importance of this separate cycles of systole and diastole of the atria and ventricles will be described in details during these two lectures. Contraction of a cardiac chamber occurs as a result of the spread of excitation across the heart, whereas relaxation follows the subsequent repolarization of the cardiac musculature. So after the cardiac musculature finishes with repolarization, it begins to relax. Contraction of the ventricles generate pressure changes, and these pressure changes result in orderly movement of the blood. So the ventricles, the left and the right ventricles, are considered to be flow and pressure generators. What are the events which we have during the cardiac cycle? We have electrical events which are represented by electrocardiographic changes. These electrical changes result in mechanical events or mechanical phases of the cardiac cycle, and the mechanical events result in pressure changes and volume changes, and we also have hard sounds during the cardiac cycle. So the electrical events result in excitation of the cardiac musculature, and these are shown as ECG changes. These electrical events result in contraction followed by relaxation, and these are the mechanical events which happen during the cardiac cycle. These mechanical events result in ventricular pressure changes, ventricular volume changes, and closure of the valves producing heart sounds, and also opening of the valves, and aortic pressure changes, changes in the aortic blood pressure, and changes in the right atrial pressure, and changes in the jugular venous wave forms. So we are going to describe these electrical events and the mechanical phases of the cardiac cycle, and these ventricular pressure changes, ventricular volume changes, the heart sounds, the aortic pressure changes, and the right atrial pressure changes, and the accompanied jugular venous wave forms changes in details during these 2 lectures. And before we describe these changes in details, let's review the ventricular volumes very briefly. The end diastolic volume, EDV, this is the volume of the blood in each ventricle at the end of diastole. It is about 110 to 130 milliliters of blood. So the end diastolic volume of the left ventricle is equivalent to the end diastolic volume of the right ventricle. The end systolic volume, the ESV, this is the volume of blood in each ventricle at the end of systole. It is about 40 to 60 milliliters of blood remain by the end of systole in the left ventricle, and 40 to 60 milliliters of blood remain by the end of systole in the right ventricle. The volume of the blood which is pumped by each ventricle per beat is known as the stroke volume, and this is equivalent to the difference between the end diastolic volume and the end systolic volume. So it is about 70 milliliters of blood ejected from the left ventricle into the aorta, and 70 milliliters of deoxygenated blood ejected by the right ventricle into the pulmonary trunk. So the flow generated by the 2 ventricles is equal. However, the flow which is generated by the left ventricle is generated with much higher pressure than the flow generated by the right ventricle. The diastolic filling volume, DFV, this is the volume of blood which flows from the atrium into the ventricle during diastole. It is equal to the difference between the end diastolic volume and the end systolic volume. So it is about 70. It is equivalent to the stroke volume. So now let's describe the mechanical events, the phases during the cardiac cycle in more details. Each cardiac cycle or heartbeat consists of 2 major periods or 2 major phases, systole and diastole. The atria and the ventricles, they go through separate cycles of systole and diastole. So we have atrial systole and atrial diastole, and ventricular systole and ventricular diastole. Normally, diastole is longer than systole. The ventricular systole lasts for approximately 0.3 of a second at rest, and the ventricular diastole lasts for 0.5 of a second at rest. Atrial systole lasts for 0.1 of a second at rest, and atrial diastole lasts for 0.7 of a second at rest. So normally diastole is longer than systole, and the importance of the long ventricular diastole is that during ventricular diastole the ventricles are filled with blood, so this allows enough time for the ventricles to get filled with adequate amount of blood, and also important for coronary blood flow, because most of the coronary blood flow, approximately 70% of the coronary blood flow, occurs during ventricular diastole. Here we have a table which summarizes the mechanical events, the phases during the cardiac cycle. So we have the ventricular diastole and ventricular systole. The ventricular diastole itself is further subdivided into a number of phases. We have the protodiastole, then we have the isometric relaxation phase, the rapid filling phase, and these three phases together belong to early ventricular diastole. Then we have the reduced, the slow filling phase, and this phase is the mid-ventricular diastole. And we have the atrial systole, which coincides with the late ventricular diastole. The ventricular systole is further subdivided into three phases: the isometric contraction phase, the rapid ejection phase, and the reduced or the slow ejection phase. In describing these mechanical events during the cardiac cycle, we might begin with any of these 8 mechanical phases. However, I usually prefer to begin describing the mechanical events of the cardiac cycle with describing the rapid filling phase. So I consider the rapid filling phase as phase 1 of the cardiac cycle, then the reduced filling phase is phase 2, phase 3 is the atrial systole, phase 4 is the isometric contraction phase, phase 5 is the rapid ejection phase, phase 6 is the reduced ejection phase, then phase 7 is the protodiastole, phase 8 is the isometric relaxation phase. Here we have the 8 phases of the cardiac cycle, the 8 mechanical events or 8 mechanical phases. So the rapid filling phase, this is phase 1. The reduced filling phase or the diastasis, this is phase 2. The atrial systole 3, isometric contraction phase 4, rapid ejection phase 5, reduced ejection phase 6. Then we have the protodiastole, this is 7, isometric relaxation phase is 8. We will first describe the rapid filling phase because I consider this as phase 1 of the cardiac cycle, and then we will describe the subsequent phases of the cardiac cycle. So the rapid filling phase, this is one of the phases of early diastole. During this rapid filling phase, the sinoatrial node has not yet reached the threshold, so the atrium is still in diastole. Because of the continuous inflow of blood from the venous system into the atrium, atrial pressure slightly exceeds ventricular pressure, even though both chambers are relaxed. And for simplicity in describing the mechanical phases of the cardiac cycle, we shall focus on the mechanical phases of the left side of the heart, and then we will compare these mechanical phases with the mechanical phases in the right side of the heart. Because of this pressure differential, because the pressure in the left atrium slightly exceeds the pressure in the left ventricle, the mitral valve is open and blood flows directly from the left atrium into the left ventricle. And approximately 60 to 70% of the blood passes passively from the left atrium to the left ventricle along pressure gradient, because the left atrium has not yet begun its systole, so it is still in diastole. So 60 to 70% of the blood passes passively from the left atrium into the left ventricle along this pressure gradient. So the left ventricular volume increases rapidly, and the left ventricular pressure begins to rise, and the atrial pressure starts to decrease because of the rapid movement of blood from the left atrium into the left ventricle. During this rapid filling phase, a third heart sound may be heard. What about the aorta? The aortic pressure is still low because the left ventricle has not yet begun ejection of the blood into the aorta, and blood keeps flowing from the aorta to the tissues, so the aortic pressure is still low. This rapid filling phase corresponds to the TP interval on the ECG. It is the interval after ventricular repolarization and before the beginning of another atrial depolarization. The rapid filling phase is followed by a reduced filling phase, which is also known as the diastasis. And while the rapid filling phase belongs to early diastole, the reduced filling phase, the diastasis, belongs to the mid-ventricular diastole. So during the reduced filling phase, the slow filling phase, the atrioventricular valve, the mitral valve, is still open, and the remaining of the atrial blood flows slowly into the ventricles. So the left ventricular volume increases more slowly, and the left ventricular pressure gradually increases. Still, the aortic valve is still closed, and no blood has been ejected into the aorta, so the aortic pressure is still low. Again, this phase corresponds to the TP interval on the ECG. After the slow filling phase, the reduced filling phase, we have the atrial systole, which coincides with the late ventricular diastole. So now the SC node has reached the threshold level and fires an action potential, fires a cardiac impulse. The impulse spreads through the atria, resulting in atrial depolarization, and this is shown as a P wave in the ECG. This is the ECG, and this is a P wave here. Atrial contraction, atrial systole, lasts for about 0.1 of a second, as we mentioned earlier, and because of atrial systole, the pressure in the left atrium rises, and this gives an A wave in the atrial pressure curve. So this is the atrial pressure curve, and this is an A wave due to an elevated atrial pressure as a result of atrial contraction, as a result of atrial systole. Throughout atrial contraction, atrial pressure slightly exceeds the ventricular pressure because the atria are in systole. So the atrioventricular valves remain open, and more blood is squeezed from the left atrium into the left ventricle, and this tops off the last 27 to 30% of the ventricular filling, about 40 mils, this rises the ventricular pressure. And now, so here we have, this is a curve which represents pressure changes in the left ventricle and pressure changes in the aorta. And here we have a curve which represents volume changes in the left ventricle. So by the end of atrial systole, the left ventricle would have been filled with the end diastolic volume, which averages about 135 milliliters. So this is the end diastolic volume. This curve shows left ventricular volume changes during the cardiac cycle. So this is the end diastolic volume, which is approximately 135 milliliters of blood. Now, blood arriving the heart cannot enter the atrium. It flows back up into the jugular vein here in the right side, and during this atrial systolic phase, a fourth heart sound may be heard. Still, the aortic pressure is low because the left ventricle is still in diastole and the aortic valve is closed and no blood is yet ejected into the aorta. Is atrial systole important for ventricular filling? At rest, atrial contraction adds little extra blood to the ventricles. This curve shows the left ventricular volume changes. So this is the atrial systole. And as you can see here, atrial systole adds little extra blood to the ventricles at rest. However, when the heart rate is high, for example during exercise, ventricular filling time is reduced and atrial contraction adds a substantial amount of blood to the ventricles. So the effect of atrial contraction on ventricular filling is important when the heart rate is high during exercise. Now, ventricular systole is going to begin, and the first phase of ventricular systole is what we call the isometric or the isovolumetric ventricular contraction phase. So now the cardiac impulse passes through the AV node and the specialized conduction system to excite the ventricles, resulting in ventricular depolarization, which is seen as QRS complex in the ECG. This is followed by ventricular contraction, so the ventricular pressure immediately exceeds the atrial pressure. This results in closure of the atrioventricular valves and the first heart sound is heard. So this is S1. So S1 is heard at the beginning of the isometric ventricular contraction phase. the aortic valve is still closed, and the left ventricular pressure must continue to rise before it exceeds the aortic pressure in order to open the aortic valve. The left ventricle will not be able to open the aortic valve until unless the left ventricular pressure exceeds the aortic pressure. Because no blood enters or leaves the left ventricle during the isometric ventricular contraction phase, the left ventricular chamber remains at a constant volume, which is the 135 milliliters of blood, and the muscle fibers remain at constant length, but they continue to contract, and it is because of that this phase of systole is known as the isovolumetric or the isometric ventricular contraction. There is no change in the volume of the left ventricle or the right ventricle. The importance of this phase lies in the fact that since no blood enters or leaves the ventricles, and the ventricles continue to contract without shortening, the left ventricle generates pressure which is now enough to open the aortic valve, and the right ventricle generates enough pressure to open the pulmonary valve. So this period lasts for about 0.04 to 0.05 of a second until the pressures in the left ventricle exceeds the pressure in the aorta and the aortic valve opens. So can you see here, this is the changes. This is now the left ventricular pressure during the isometric contraction phase. It was initially approximately 3 or 4 millimeters of mercury, and during the isometric contraction phase it increases, and when it reaches 80 and slightly above 80, it opens the aortic valve. During the isometric contraction phase, the AV valve bulges into the atrium, the mitral valve bulges into the left atrium, and this causes a small but a sharp rise in the left atrial pressure, and this is seen as a C wave in the atrial pressure curve. Since no blood is still ejected into the aorta, and blood leaves the aorta going to the tissues, the aortic pressure is still low. The isovolumetric ventricular contraction phase ends by opening of the aortic valve. And when this happens, the maximum ejection phase begins. So contraction of the ventricle, of the left ventricle, rises the intraventricular pressure, and when the left ventricular pressure exceeds the aortic pressure, i.e. at approximately 80 millimeters of mercury, the aortic valve is forced open and ejection of the blood begins. And when ejection of the blood begins, left ventricular volume decreases. Ejection is rapid during this phase and then slows down as systole progresses during the subsequent phase, during the slow ejection phase. So ventricular volume decreases substantially as blood is rapidly pumped into the aorta, and the ejected volume of blood is the stroke volume is about 75, which is 70 milliliters of blood, about 75% of the ejected 70 milliliters, the stroke volume, is ejected during this rapid ejection phase. The remaining volume is the end systolic volume when the slow ejection phase ends. So blood is ejected into the aorta and is forced into the aorta faster than blood is drained off into the smaller vessels at the other end, and this results in an increase in the aortic pressure. So this curve is the aortic pressure curve. So the aortic pressure here is 80 at the end of the isometric contraction phase, and during the rapid ejection phase, what happens? The aortic pressure increases. Peak pressures in the left ventricle is about 120 millimeters of mercury, and late in systole, pressure in the aorta actually exceeds the pressure in the left ventricle. However, for a short period, the momentum, the movement of the blood keeps the blood moving forward from the left ventricle into the aorta despite the slightly elevated aortic pressure. The atria are in diastole during the rapid ejection phase of the ventricles, and the AV valves are pulled down during the rapid ejection phase, and this results in an X-descent in the atrial pressure curve. So this is the X-descent in the atrial pressure curve, which is due to pulling down of the atrioventricular valves during the rapid ejection phase of the cardiac cycle. The rapid ejection phase is followed by the slow or the reduced ejection phase, and this is the last phase of ventricular systole. Ejection is slow, so the ventricular volume decreases more slowly, and the remaining 25% of the stroke volume is ejected during this phase, and now the volume which remains is the end systolic volume, about 65 milliliters or 70 milliliters. The intraventricular pressure declines somewhat before ventricular systole ends. So this is the left ventricular pressure reaching the maximum value of 120 millimeters of mercury during the rapid ejection phase and the early part of the slow ejection phase. Then the intraventricular pressure declines before the ventricular systole ends, and the aortic valve closes at the end of this phase. And closure of the aortic valve is the result of the decreased ventricular pressure. Is now the decrease in the ventricular pressure is lower than the aortic pressure, or the aortic pressure is slightly higher than the left ventricular pressure. So when the left ventricular pressure is about 110 millimeters of mercury, we have aortic back pressure, which closes the aortic valve. The atria are still in diastole and receiving blood. This slow or reduced ejection phase, this is the last phase of ventricular systole, and now ventricular diastole begins. And ventricular diastole begins with a phase known as protodiastole. The T wave on the ECG signifies ventricular repolarization, And ventricular repolarization occurs at the end of ventricular systole. Now, when the ventricles finish with repolarization, they begin to relax and undergo diastole. The already falling ventricular pressure drops more rapidly, and this is what is known as the period of protodiastole, which lasts for a very brief period of time, approximately 0.04 of a second. Physiologists have different opinion about the existence of the protodiastolic phase of the cardiac cycle. Some physiologists believe in its existence, and they think that the aortic valve has not yet closed by the end of the slow ejection phase, and that the protodiastolic phase is the period between the end of ventricular systole and the closure of the aortic valve. Thus, protodiastole ends when the momentum of the ejected blood is overcome and with the aortic valves, the clasps of the aortic valve close. And when this happens, this sets up transient vibrations in the blood and blood vessel walls, resulting in the generation of the S2, the second heart sound. After the aortic valve closes, pressure continues to drop rapidly in the left ventricle during the isometric relaxation phase which follows. And the left atrium is still in diastole, and the left atrial pressure continues to rise as a result of the continuous return of blood from the pulmonary circulation. However, still the atrial pressure is lower than the ventricular pressure, and accordingly the mitral valve is still closed. The protodiastolic phase of diastole is followed by the isometric or the isovolumetric relaxation phase. So when the aortic valve closes, the atrioventricular valve is still closed, is not yet open, because the left ventricular pressure still exceeds left atrial pressure. So all the valves are once again closed for a very brief period of time, and no blood can enter or leave the ventricle. And the muscle fiber length and the left ventricular chamber volume remain constant at the end systolic volume, which is 65 milliliters of blood. The importance of the isometric or the isovolumetric ventricular relaxation phase lies in the fact that it is during this phase, because of the isometric relaxation of the ventricular musculature, the left ventricular pressure drops markedly. So as the ventricles continue to relax, the pressure steadily falls, and the atria are still in diastole. So the atrial pressure continues to rise due to the movement of blood from the pulmonary circulation into the left atrium, and this continuous venous return of blood into the left atrium gives the V wave in the atrial pressure curve. However, still again, left atrial pressure is lower than left ventricular pressure, and the mitral valve is still closed. It is only when the left atrial pressure exceeds the left ventricular pressure that the mitral valve opens, and this happens at the end of the isometric relaxation phase. So the mitral valve opens at the end of the isometric relaxation phase, and this phase thus represents the beginning of diastole, and it's the quiescent period. This isometric relaxation phase is the quiescent period between the closure of the aortic valve and the opening of the mitral valve, and it lasts for about 0.04 of a second. So it is a brief phase of a cardiac cycle. Again, the importance of this phase lies in the fact that left ventricular pressure steadily falls, and when the left atrial pressure exceeds the left ventricular pressure at the end of this phase, the mitral valve opens and left ventricular filling begins again, with the rapid filling phase followed by the slow filling phase. Then we have atrial systole, and the phases of the cardiac cycle are repeated again. So ventricular filling. So because of the continuous flow of blood from the pulmonary veins into the left atrium, atrial pressure rises continuously, and when the left ventricular pressure falls below the atrial pressure, the mitral valve opens and ventricular filling occurs once again. Atrial pressure drops as a result of the filling of the ventricles, the movement of blood from the left atrium into the left ventricle, and this gives a Y descent in the atrial pressure curve. And this was explained before, the rapid and the slow ventricular filling phases of the cardiac cycle. So again, this curve represents changes in the left ventricular volume during the different phases of the cardiac cycle. This is the end diastolic volume, 135 milliliters of blood. Still, this is the volume of blood in the left ventricle during the isometric contraction phase, no change in the volume. Still, it is the end diastolic volume, 135 milliliters of blood. The volume decreases during the rapid ejection phase and continues to decrease but slowly during the slow ejection phase. And this is now the end systolic volume, the volume which remains by the end of systole. This is the volume during the isometric relaxation phase, the same end systolic volume. Now this is the rapid filling phase, followed by the slow filling phase. These are the pressure changes curves, the left ventricular pressure curve and the aortic pressure curve. So this is the left ventricular pressure, approximately 0 or 3 to 4 millimeters of mercury, and the pressure increases during the isometric contraction phase, and when the left ventricular pressure exceeds the aortic pressure, the aortic valve opens. The left ventricular pressure continues to rise during the rapid ejection phase and the early part of the slow ejection phase, and reaches a maximum value of 120 millimeters of mercury. Then it declines somewhat before the end of the ventricular systole. So this is the end of ventricular systole. The aortic valve closes here. Then we have the protodiastolic phase, and we have the isometric relaxation phase. The left ventricular pressure steadily falls, and when the left atrial pressure exceeds the left ventricular pressure, the mitral valve opens. So here again we have the left ventricular pressure changes during the phases of the cardiac cycle, and here we have the left ventricular volume changes during the different phases of the cardiac cycle. The normal left ventricular pressure during the cardiac cycle is about 120 millimeters of mercury. This is the maximum left ventricular pressure which is reached during the rapid ejection phase, and it is about, say, 3 up to 12 millimeters of mercury during diastole. So the stroke volume, this is the end diastolic volume, and this is the end diastolic volume, approximately 135 milliliters of blood in the left ventricle and 135 milliliters of blood in the right ventricle, and this is the end systolic volume. So the end diastolic volume is the maximum volume, and the end systolic volume is the minimum volume. Stroke volume is the difference between the end diastolic volume and the end systolic volume. So it is the amount of the blood which is ejected in one heartbeat. An increase in the force of contraction of the ventricles results in an increase in the stroke volume. The ejection fraction is the stroke volume divided by the end diastolic volume multiplied by 100. So it is the percentage of the blood which is ejected. It is the percentage of the end diastolic volume which is ejected in one beat. So the ejection fraction, it is the proportion or the percentage of the end diastolic volume which is pumped in a single beat. Ejection fraction can be a diagnostic indicator of heart function. Normally, the ejection fraction is about 65%. So 65% of the end diastolic volume is ejected during ejection, the rapid and the slow ejection phase. Here we have the left ventricular pressure volume loop. This is a loop which shows the relationship between changes in left ventricular volume on the x-axis and changes in the left ventricular pressure in millimeters of mercury on the y-axis. So this is the end systolic volume, about 65 milliliters, and now this is filling of the left ventricle. This is the period of filling. So the left ventricle, the volume by the end of systole was 65 milliliters of blood, and now it is in relaxation in diastole, and by the end of diastole the volume is about, say, 130 milliliters of blood. So this is the end diastolic volume. Then the left ventricle begins systole, and the first phase of systole is the isometric contraction phase. And at the beginning of the isometric contraction phase, the left ventricle closes the mitral valve. So the moment the left ventricle begins to contract, it generates enough pressure to close the mitral valve. However, still the left ventricular pressure is not enough to open the aortic valve. So the mitral valve is closed and the aortic valve is still closed, and the left ventricle undergoes the isometric contraction phase of the cardiac cycle. And the physiological significance of this isometric contraction phase is to increase the pressure. So can you see now we are moving on the y-axis. So the pressure elevates, increases, and when the left ventricular pressure exceeds the aortic pressure at about 80 millimeters of mercury, the aortic valve opens and ejection of blood begins. So now we'll move along the x-axis. So ejection at first is rapid, and during the rapid ejection phase, still the left ventricular pressure elevates because the left ventricle keeps on contracting. So the left ventricular pressure increases, reaching a maximum value of 120 millimeters of mercury, but its volume is decreasing because the volume is, we are moving from right to left on the x-axis. So the volume is decreasing, but the pressure is increasing. So this is the rapid ejection phase, followed by the slow ejection phase. So before the end of left ventricular systole, as we mentioned earlier, left ventricular pressure decreases somewhat. And at about, when the aortic pressure is about 110 millimeters of mercury, the aortic valve closes. And the left ventricle now begins with diastole. So the volume of blood which remains in the left ventricle at the end of systole is the end systolic volume. So now the aortic valve is closed, and the mitral valve is still closed because still the left ventricular pressure is higher than the left atrial pressure, despite the continuous flow of pulmonary blood into the left atrium. And now the left ventricle relaxes isometrically. This is the isovolumetric relaxation phase of the cardiac cycle. And the physiological significance of this phase is now during this phase, left ventricular pressure, the volume doesn't change, but left ventricular pressure steadily falls. And when the left atrial pressure exceeds left ventricular pressure, the mitral valve opens. So now the difference, this is the volume of the blood which is ejected in one beat. This is the stroke volume, which is the difference between the end diastolic volume and the end systolic volume. So having finished with the detailed description of the phases, of the mechanical phases of the cardiac cycle, let's very briefly describe the basic myocardial mechanics. So ventricular systole and diastole can be subdivided into early and late phases. So systole is divided into early systole, and this coincides with the isometric contraction phase, and late systole, which coincides with the isotonic contraction phase. The ejection phase is the rapid and the slow ejection phases. Diastole is subdivided into early diastole, which coincides with the isovolumetric relaxation phase, and late diastole, which coincides with the isotonic relaxation phase, where we have the rapid and the slow filling phases. So here again we have the left ventricular volume pressure loop showing the early and late systole and diastole. So this is the early diastole of the left ventricle, which coincides with the isometric relaxation phase, and this is the late diastole of the left ventricle, which coincides with the period of filling. So this is where we have the isotonic relaxation. Then here we have the early systole, which coincides with the isometric contraction phase, and the late systole, which coincides with the period of ejection, the ejection phases. Ventricular systole is measured by contractility, and it is affected by the function of the ventricular muscle and by the initial volume of the blood which is present in the ventricle before systole begins, and this is known as the preload, and is also affected by the initial pressure, the pressure which the left ventricle faces when it begins to contract, and this is known as the afterload, because when the left ventricle begins to contract, it faces the resistance in the aorta and in the systemic arteries, and it has to develop a pressure which exceeds the aortic pressure in order to open the aortic valve. This initial pressure is known as the afterload. Ventricular diastole is measured by the compliance, is measured by the change in the ventricular volume, which is brought about by change in pressure. And it is affected by the amount of connective tissue we have in the ventricles and by the venous pressure and venous resistance, and this will be described in details in the lecture on venous return. So we have described left ventricular pressure changes and left ventricular volume changes during the different phases of the cardiac cycle in more details, and we have also described aortic pressure changes during the cardiac cycle. And let's now describe the aortic pressure changes in more details. So this is the diastolic pressure in the aorta. This is the minimum pressure in the aorta, which is 80 millimeters of mercury, and this minimum pressure of 80 millimeters of mercury is reached just before the ventricle, the left ventricle, begins to eject blood into the aorta. The maximum systolic pressure in the aorta is 120 millimeters of mercury, and this is reached during the rapid ejection phase of the cardiac cycle. So the aortic pressure curve shows an ascending or an anacrotic limb and a descending or catacrotic limb. The ascending limb coincides with the rapid ejection phase of the cardiac cycle, where the amount of blood which enters into the aorta is more than the amount of blood which leaves the aorta and goes to the tissues. So the aortic pressure increases up to a maximum level of 120 millimeters of mercury. The descending, the catacrotic limb, has 4 stages. It passes in 4 stages. So this is the first stage, where the aortic pressure decreases, and this coincides with the reduced ejection phase, where the amount of blood which enters into the aorta is less than the amount of the blood which leaves the aorta, and it is because of that the aortic pressure decreases. This decrease in the aortic pressure is followed by the dicrotic notch or the incisura, and this is due to closure of the aortic valve. So there is sudden drop in the aortic pressure. This notch is seen in the aortic pressure curve at the end of ventricular systole. So this signifies the end of ventricular systole and the closure of the aortic valve. Then we have a dicrotic wave. This is where the pressure slightly increases in the aorta, and this happens as a result of the elastic recoil of the aorta. When the aorta receives the stroke volume, it expands because it is an elastic artery. Now the aorta recoils, and the elastic recoil of the aorta results in slight increase in the aortic pressure, giving rise to the dicrotic wave in the aortic pressure curve. Then the fourth stage is slow decrease in the aortic pressure up to a minimum pressure of 80 millimeters of mercury, and this is due to the continuous flow of blood from the aorta into the systemic arteries and the systemic circulation. So the minimum aortic pressure is the diastolic pressure is 80 millimeters of mercury, and the maximum aortic pressure is the systolic pressure, which is 120 millimeters of mercury normally, and is reached during the rapid ejection phase. The pulse pressure, this is the difference between the systolic pressure and the diastolic pressure. This is the pulsatile component of the aortic pressure, because during the successive cardiac cycles, the aortic pressure keeps on increasing from 80 to a maximum of 120, then decreasing to a minimum of 80, then increasing again to 120 millimeters of mercury, then decreasing again to a minimum of 80 millimeters of mercury. So this pulsatile component, which is the difference between the maximum pressure and the minimum pressure, the difference between the systolic pressure and the diastolic pressure, is what we call the pulse pressure, which is normally 40 millimeters of mercury. An increase in the pulse pressure can indicate hardening of the arteries, because as we mentioned in the previous lectures, the arteries are considered as pressure reservoirs. The mean arterial pressure, this is the mean pressure in the aorta and in the systemic arteries during the entire cardiac cycle. This mean arterial pressure is not equal to the sum of the systolic pressure and the diastolic pressure divided by 2. In fact, the mean arterial pressure is, the aortic pressure is closer to the minimum value, is closer to the diastolic pressure for a longer period of time than it is close to the maximum value, because the duration of left ventricular diastole is 0.5 of a second, and the duration of left ventricular systole is 0.3 of a second at rest. So the diastolic period of the cardiac cycle lasts for about 2/3 of the cardiac cycle, and the systolic period of the cardiac cycle lasts for about 1/3 of the heartbeat. So the mean arterial pressure, the mean pressure in the aorta, is thus equivalent to 1/3 of the systolic pressure plus 2/3 of the diastolic pressure. 1/3 of the systolic pressure is 40 millimeters of mercury, and 2/3 of the diastolic pressure are 53 millimeters of mercury, so the mean arterial pressure is about 93 millimeters of mercury. Another equation which we might use for calculating the mean arterial pressure is that the mean arterial pressure is equivalent to 1/3 the pulse pressure plus the diastolic pressure. Now, this mean arterial pressure is the driving force for blood flow. So again, here we have the maximum aortic pressure, the systolic pressure, 120 millimeters of mercury. This is the end of ventricular systole and closure of the aortic valve. This is the minimum pressure in the aorta, the diastolic pressure, the 80 millimeters of mercury, and this is the mean pressure, the mean arterial pressure. Pulmonary artery pressure changes are similar to the aortic pressure changes, but with difference in magnitude. In fact, the pressure in the aorta is 6 to 7 times higher than the pressure in the pulmonary artery. So normal pulmonary artery pressure during the cardiac cycle is approximately 25 to 30 millimeters of mercury during systole and 4 to 12 millimeters during diastole. Here we have a diagram which shows pressure changes in the peripheral arteries. So here we have, this is the carotid artery. This is the pressure changes in the carotid artery during the cardiac cycle. Here we have the pressure changes in the brachial artery. This is radial artery. So we have pressure changes similar to the aortic pressure waves, but the changes are sharper than the changes which we have in the aorta, and this reflects a systolic peak pressure of 110 to 130 millimeters of mercury and a diastolic pressure of 70 to 90 millimeters of mercury. Having finished with the detailed description of the aortic pressure changes during the different phases of the cardiac cycle, let's describe atrial pressure changes during the cardiac cycle, and we mentioned these changes briefly when we described the different phases of the cardiac cycle. So now let's describe these atrial pressure changes in more details. We have 3 upward waves or 3 upward deflections, A, C, and V. And we have two components in each of these upward waves or upward deflection. Positive component indicating an increase in the pressure, and a negative component indicating a decrease in the pressure. And we also have 2 downward waves or 2 downward deflections, which are the X and the Y descents, or the X and Y waves. The 3 waves, the A, C, V waves, are equal to 1 cardiac cycle. So their duration is equivalent to 0.8 of a second. The A wave in atrial pressure curve coincides with atrial systole, where we have an increase in atrial pressure during atrial contraction. The C wave coincides with ventricular systole, and it has got a positive wave as a result of bulging of the atrioventricular valves into the atria during the isovolumetric contraction phase. And so this is the positive component of the C wave due to bulging of the atrioventricular valves into the atria during the isometric contraction phase. And the negative component is the result of pulling of the atrial muscle and the AV clasps down during the rapid ejection phase of the cardiac cycle, resulting in a decrease in the atrial pressure. Then the V wave, this happens during atrial diastole as a result of the continuous flow of blood into the atria, and it also has a positive component, so the atrial pressure increases gradually due to the continuous venous return from the pulmonary circulation into the left atrium and from the systemic circulation into the right atrium. And the negative component is the result of the decreased atrial pressure during the rapid filling phase. The X descent in the atrial pressure curve signifies the downward displacement of the AV valves during the reduced ejection phase, and the Y descent signifies the decrease in atrial pressure during the reduced filling phase. Atrial pressure changes during the cardiac cycle result in changes in the jugular venous pulse wave forms during the cardiac cycle. So changes in right atrial pressure during the cardiac cycle results in changes in the jugular venous pulse wave forms during the cardiac cycle, because there are no valves between the right atrium and the superior vena cava and the internal jugular vein. So the atrial pressure changes are transmitted to the great veins, producing three characteristic waves in the record of the jugular pressure. So here we have, these are the right atrial pressure changes, the ACV upward waves, and the X and the Y descents. Same thing here, we have the A, C, and V waves in the jugular venous pressure curve. So again, the jugular venous pulse wave forms is shown in this diagram. The A wave is a visible pulsation. We can see it in the internal jugular vein in the neck during the cardiac cycle. The V wave is also a visible pulsation. We cannot feel these pulsations, by the way. If we try to feel them with our fingers, we will not feel them, because these are venous pulsations. The venous pulsations are seen and not felt, whereas the arterial pulsations can be felt. So here we have a summary of the events of the cardiac cycle. So we have left ventricular pressure changes, left ventricular volume changes, aortic pressure changes, left atrium pressure changes, and we have heart sounds, and we have electrical changes which are seen as the ECG waves, and we have described all these changes and in pressure, in volume, and the generation of the heart sounds in the previous slides. And here we have a summary of the electrical changes during the cardiac cycle. So P wave is recorded before the onset of atrial systole. QRS complex is recorded before the onset of ventricular systole. And the T wave is recorded before the onset of ventricular diastole. In fact, by the end of the T wave, when the ventricles finish with repolarization, the ventricles begin to relax and undergo diastole. And lastly, few comments on the cardiac cycle timing. So although the events of the cardiac cycle on the two sides of the heart are similar, they are somewhat asynchronous. They are asynchronous to a very little extent. Right atrial systole precedes left atrial systole because the right ventricle gets depolarized before the left atrium, and right ventricular systole starts after that of the left ventricle. However, since the pulmonary arterial pressure is lower than the aortic pressure, right ventricular ejection begins before that of the left ventricle, because the right ventricle generates much lower pressure than the pressure generated by the left ventricle in order to open the pulmonary valve against the pulmonary arterial pressure, which represents the right ventricular afterload. During expiration, the pulmonary and the aortic valves close at the same time. However, during inspiration, the aortic valve closes slightly before the pulmonary valve, and this results in physiological splitting of the second heart sound, which will be explained in details in the subsequent lecture. When measured over a period of minutes, the outputs of the two ventricles are equal. However, transient differences in the output during the respiratory cycle occur in normal individuals. So left ventricular output is equivalent to right ventricular output when the output is measured over a period of minutes. However, again, as we mentioned earlier in the lectures, the left ventricular output is produced with much higher pressure than the right ventricular output, because the left ventricular output is going through the systemic circulation, while the right ventricular output is going through the pulmonary circulation. Length of systole and diastole. We mentioned that the duration of systole decreases from about 0.27 or 0.3 of a second at a heart rate of 65 beats per minute to 0.16 of a second at a heart rate of 200 beats per minute. However, the duration of systole is much more fixed than the duration of diastole. When the heart rate is increased, diastole is shortened to a much greater degree than systole. For example, at a heart rate of 65 beats per minute, the duration of diastole is about 0.62 of a second, whereas at a heart rate of 200 beats per minute, the duration of diastole is only 0.14 of a second. So when the heart rate is high, diastole is shortened to a much greater degree than systole. There are physiological and clinical implications of the shortened diastole when the heart rate is increased. The heart muscle rests during diastole, and coronary blood flows to the subendocardial portions of the left ventricle only during diastole. Furthermore, we know that most of the ventricular filling occurs in diastole. So at heart rates up to 180 beats per minute, ventricular filling is still adequate as long as there is enough venous return, and the cardiac output per minute is increased as a result of the increase in the heart rate. However, at very high heart rates, diastole is very much shortened, and filling of the ventricle may be compromised to such a degree that the cardiac output per minute falls. And the coronary blood flow to the subendocardial portions of the left ventricle are also affected at very high heart rates because the duration of diastole is shortened to a much higher degree. That's the end of these two lectures, and here we have the intended learning outcomes, the ILOs again, which you need to revise because these ILOs should direct your learning and should also direct the level of the learning which you should have acquired after you have reviewed the PowerPoint presentation and the associated learning resources for these two learning activities, for these two lectures. And thank you very much for listening.